You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 5th, 2019. This week, ARB recalls, cardiac arrest, renal denervation, a new LDL target, and preoperative pearls. First is the ARB recall. Now, my initial response to this problem was to ignore it, hoping that it went away. But it hasn't. It's the opposite. The number of recalls due to cancer-causing contaminants has increased. And there are many layers to this problem, and each has a specific lesson. Patrice Wendling from theheart.org Medscape Cardiology has written an in-depth piece on this, and it's worth a look. J. Brian Bird and co-authors also have a useful summary in the New England Journal of Medicine. So problem number one is the contaminants. There are now three, 2 amines and a butyric acid. They have long chemical names, and I'll use only the abbreviations NDMA, NDEA, and NMBA. These are known as genotoxic impurities because they damage DNA. Now we're talking parts per million here. And in December of 2018, FDA announced that it had set interim acceptable limits. And they estimate that these limits would confer a 1 in 100,000 risk of causing cancer after 70 years of exposure. The impurities probably occurred in the making of the drugs, but not by the generic pill makers themselves, but rather upstream from the small number of companies that make the actual active pharmaceutical ingredients. That I did not know before reading the story. The second problem here is the risk trade-off. So FDA estimates that taking in these very low levels of NDMA is, quote, reasonably safe, but then they also estimate that the impurities may have been in valsartan products for as long as 4 years. And if so, another estimate is that there may be one additional case of cancer for every 8,000 patients taking the highest dose of recalled products. So that tiny individual risk of cancer is one side of the problem, but the other side, of course, is the harm from switching to a different drug, or patients with severe hypertension not taking drugs because they fear cancer. I'm not a statistician or ethnographer, but my experience in the clinic tells me that people struggle with these sorts of stochastic risks. Even if it is 100 times less risky to stay on a drug with contaminants than it is to switch, people will want to switch. Cancer is a tail event with downside asymmetry, and it will affect behavior. Problem number 3 here is the regulation and inspection aspect of generic drugs. And FDA, no doubt, has a tough task because the vast majority of ingredient manufacturers are outside the U.S. The ARB recall has really exposed a challenge for entire health systems. For instance, in my office, we're struggling to keep up with which particular generics have been recalled. Then there is the issue with pharmacies. Which manufacturer do they carry? I mean, we have medical assistants calling pharmacies a lot to check for patients. Perhaps the next time this happens, FDA will have learned a lesson and maybe offer a better way to disseminate information in a clear and usable way. The fourth problem with this is to see the issue through the lens of a medical conservative. Medical conservatives recognize the potential harms from healthcare. Drugs, devices, surgery, surely these things do a lot of good, but they also come with potential harms. Humans make and regulate these therapies, and we are imperfect creatures, so tainted drugs and malfunctioning pacer and ICD leads will always be part of healthcare. The medical conservative, therefore, does everything she or he can to get patients to avoid healthcare. Medical conservative asks, what benefit is there in treating mild hypertension in a 40-year-old, say with a blood pressure of 140, or a 90-year-old with a blood pressure of 160 to 170? The medical conservative spends extra time to help patients treat hypertension with weight loss and diet, for instance. And the medical conservative critically appraises the literature, and don't even get me started on the absolute benefits of renal protection with ARBs. Next topic today is compression-only CPR. So medical conservatives like to think long and hard about the benefits and harms and cost of therapies, but thinking is not good for cardiac arrest. Here, fast action is a must. And when cardiac arrest happens outside the hospital, the patient depends on bystanders for fast action. Swedish investigators were interested in studying the effects of compression-only CPR, which for bystanders is obviously a preferred strategy over standard CPR, as ventilating a stranger with mouth-to-mouth breathing is, we could say, unsavory. Circulation published this ecological study looking at changes in the rate and type of CPR performed before the arrival of EMS during 3 consecutive guideline periods. Swedish authors looked at the primary outcome, 30-day mortality, in the years 2000 to 2005, 2006 to 2010, and then 2011 to 2017, as these corresponded to changes in the national CPR guidelines. And they found that the proportion of patients receiving CPR did indeed increase steadily over the time blocks, 41 to 58 to 68%. That's good. The proportion of compression-only CPR also went from 5 to 14 to 30% over those time periods. Now 30-day survival. First, in the no CPR group, survival ranged from 4 to 7% over the 3 periods. In the standard CPR, it was way better, 9% to 12% to 16% in the last time group. And the numbers were about the same for compression-only CPR survival, 8% to 11% to 14%. So any CPR associated with doubling of their survival versus no CPR, and standard CPR was slightly better than compression-only CPR with an odds ratio of 1.2. The authors felt these results support continued endorsement of compression-only CPR as an option for future CPR guidelines because it's associated with higher CPR rates and overall survival is good in out-of-hospital cardiac arrest. And I agree. This is an important study for many reasons. One is that the finding that compression-only CPR is almost as good as standard CPR is important because it's easier to teach and more apt to be used. Another reason to highlight this study is that cardiac arrest survival is so terrible, and many of those who suffer from it are young and have so much life to lose. My partner, Dr. William Dillon, who has a nonprofit dedicated to teaching CPR to the public, always says that if a person learns compression-only CPR, the most likely person they will use it on is a loved one, which I think is a compelling reason to learn it. Next topic is renal denervation for high blood pressure. Now, last week on the podcast, I discussed willy-nilly ablation for AF. A provocative study there showed that less rigorous ablation may be as good as EP-directed ablation for AFib. But here it looks to be the opposite for renal denervation. A more focused approach looks better. And Jack has published a meta-analysis of trials of the sham-controlled studies for renal denervation. This breaks down roughly as the old trials and the new trials. Now, the top-line results breathe some life back into renal denervation after the large Simplicity 3 hypertension trial came up negative. The old trials, mostly Simplicity 3 hypertension, were really sort of willy-nilly. You put a catheter in the renal artery, turn on ablation, and remove it. There were no measures of ablation, and energy was delivered very proximally in the renal artery. The new trials were different. They used either focused ultrasound, which is a completely new technology, or a more standardized approach for RF in which experienced operators only targeted all accessible renal artery branches, and this led to more complete ablation in the kidney. There were other differences also in the newer trials. For instance, the older trials enrolled patients with resistant hypertension, but the newer trials enrolled patients with just hypertension, but without treatment resistance, and in fact, 2 of the newer trials enrolled patients who were not even on blood pressure meds. So the meta-analysis in JACC showed that when combining all the renal denervation trials, blood pressure was statistically reduced by renal denervation versus sham, and the weighted mean difference was 3.65 millimeters of mercury. But when the authors compared daytime ambulatory systolic blood pressure reduction in the newer trials versus the older trials, they found the difference 6 millimeters versus -2, which was significant. However, that difference did not show up as significant when they looked at 24-hour ambulatory or office systolic blood pressure. But the take-home here is that newer renal denervation techniques hold some promise for this procedure. And these results of this meta-analysis comport with the radiosound hypertension trial published in late 2018, which found that renal denervation, especially with the ultrasound catheter, reduced systolic blood pressure significantly in patients with resistant hypertension. So 3 final points. The newer trials are small and include short-term follow-up, and of course we need longer follow-up. There are now 3 ongoing renal denervation clinical trials, and that's a good thing. And it appears that about 1 in 3 patients in these newer trials were super responders. And so perhaps there is a heterogeneous treatment effect that might be due to patients with hypertension that have high sympathetic activity. Next topic is a new LDL cholesterol target. And this report will be brief as there are no outcomes trials. But 2 studies published in the New England Journal explore the possibility of another target for reduction of LDL and CV events. And the pathway here is called ATP citrate lyase inhibition. And I know already, this sounds way out of my league in terms of the biochemistry. But for this podcast, by a clinician, for clinicians and patients, it suffices to say it's upstream from the HMG-CoA reductase pathway, which is the target of statins. Let's also set out that both New England Journal papers were studies funded by Esperion Therapeutic, which were the makers of bempedoic acid. Now, one study showed the drug bempedoic acid reduced LDL, but the incidence of adverse events leading to discontinuation of the regimen was higher in the bempedoic acid group than in the placebo group. That was 10.9% versus 7.1%. The other study was a Mendelian randomization study. Here, primary investigator Dr. Brian Ferentz explains that Mendelian randomization is nature's way of doing an RCT. Basically, they look at people born with gene mutations of the ATP citrate lyase pathway and then observe cardiovascular events. And their paper found that genetic variants that mimic the effect of ATP citrate lyase inhibitors and statins appeared to lower plasma LDL cholesterol levels by the same mechanism of action and were associated with similar effects on the risk of cardiovascular disease per unit decrease in the LDL level. Okay, so this is a possible new drug. As reported in Megan Brooks' news report, a phase 3 CV outcomes trial called Clear Outcomes is ongoing. Good. We will need that because moving cholesterol values, remember, is not the same as improving outcomes. Final topic today is preoperative evaluations. And I know, as a sexy topic, pre-op evaluation sits on the other pole from TAVR or VT ablation or any procedure like sucking clots out of some part of the vasculature in a sick patient. But guess what? If you go into medicine or cardiology, or if you're doing medicine or cardiology, pre-op evaluations are something you will see todos los días, every single day. Seriously, after 2 decades of practice at one hospital, my EHR inbox overflows with pre-op consults. One of the biggest defects I see is dependence on the metrics you can use from the chart. Past medical history, ECG, echo, people calculating risk scores. But what is really important from my standpoint for operative clearance is the eyeball test. When you look at a patient and talk with them about their activity, you are really assessing their frailty, something that's hard to put into a spreadsheet. Authors of a recent report in a journal of the American College of Surgeons hypothesized that frailty affects postoperative outcomes in a large healthcare system. And they prospectively measured frailty in a cohort of patients who were going to have elective surgery. And they used a modified Hopkins frailty score, which is based on a couple of principles. One is something called shrinking, which is unintentional recent weight loss of 10 pounds or greater in the last year. Other is hand grip strength, hemoglobin, and ASA score. Now, this was a big survey they did of over 14,000 patients, and they found that the incidence of major morbidity, readmission, and mortality correlated with frailty classification in all patients with a P less than 0.05 in the inpatient cohort. And they concluded that frailty affects morbidity, mortality, and healthcare resource use in both inpatient and outpatient operations. And that broad applicability of frailty across surgical specialties represents an opportunity for risk stratification and patient optimization across a large healthcare system. And I'd say, of course it does. And here's why this is important. Again, it gets to the medical conservative approach. Is the surgery really necessary? Does the hernia really bother the older patient that much? Will a breast biopsy change the outcome of an 88-year-old who has weight loss? Really you want to do bladder surgery in this patient who barely gets out of the house? I mean, what happens if we don't do surgery, if we don't touch the patient? Remember, if you don't mess with older people, then they don't incur harm from us. And cardiologists are often asked for cardiac clearance, but here's the thing. The heart almost always tolerates the surgery. The problem with frail elderly people is that the rest of the person often doesn't tolerate the surgery. So good on the heart.org and Medscape Cardiology for covering this vitally important survey study. So that's it for This Week in Cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider subscribing, giving us a review so that other people can find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.